We think we're back to Fertility Fact and Fiction. We had some technical difficulties there, so sorry. Mel, if you're watching somehow, jump back on the call with us. So she'll have to join into the link again. Is this a new link?
Yeah. Hold on.
Still not working?
So you're live for sure now.
I'm on YouTube because it just notified
you're
us.
on YouTube for sure.
Hello. We're experiencing some technical difficulties, but don't go anywhere. We will be right back with you in a second. I'm just going to get our panel member on with us again, Melissa McNichol. New link. Also,
so you're on everything. So you're on these things right now.
Okay.
But you're not on Instagram yet. So bear with me here.
Okay. So you have to redo it all?
I don't know why.
All right, everybody. We are just respooling the software that lets us broadcast to multiple platforms at the same time.
All right. You're not live?
On everything?
Check your
IG?
Yeah, let's check it. Yellow duck's broken.
Yellow duck is broken?
Yeah, really. Nothing's working.
I'm not seeing anything.
Oh, hold on. You might now. Okay.
We're good?
Yep. Welcome back.
Okay, welcome back. So this is Fertility Fact or Fiction. I'm your host, Dr. Rahi Vickery. Send a invite to Mel. I still don't see me live here, but that's fine.
Yeah, because it's yourself. You won't see yourself.
Oh, okay. So I don't need to worry about that.
No,
hello, everybody. Welcome back to Fertility Fact or Fiction. We have Melissa McNichol, the London Fertility Concierge, on with us. And we apologize. There was some weird technical stuff going on there with Yellow Duck, the software package we use to broadcast to 4 different platforms at the same time. So we are back in action, and we'll stay on a little longer for you all to go over things. We're just getting Mel back on. So as soon as she's joined back on with us, we will continue the show. Melissa was just telling us that her own journey included a fertility history, and that she thought that she needed something more than what was being offered. And so she's really acting as kind of a buffer between the clinic and the patients to help alleviate the stress and the kind of problems that we go through with these journeys. And Mel is back online with us. So Mel, my apologies. One of the software packages was just not behaving. So you disappeared for a bit, but I was just telling everyone what we do. Tarek is about to pass out next to me here, and welcome back. So I know you were just saying about the fact that we're quite international and you're international, and so that's great. Tell us a little bit about like some specific cases maybe you've dealt with, so people have an idea of, who you've worked with and kind of what you've done for them.
Yeah. First, what we had recorded before, was that aired?
We don't know. We're not sure. Yeah,
okay,
but
I
told everybody about it already. So
that's okay. I just didn't want to repeat myself.
Yeah, no worries.
Okay, perfect. So I think if it's okay with you, before I actually get into each case description, just to describe a little bit about the individual services that I provide, because you'll hear me mention them and maybe not know what.
Oh, for sure. Yeah, go for it.
So I do work with patients from preconception right through to parenthood. I love being the constant support for people. And I think that that's really important to not, we always go from different care providers throughout the journey. So it's nice to have somebody who is that constant. And I know that you guys at the clinic do that as well, right? To see people right through to pregnancy. So that's my goal as well. So generally, if you're in the trying to conceive area of your journey, then we usually start with what I call a fertility consultation. which is a 30, 45, or 60-minute call, depending on your needs, of course. And we will go over kind of what's got you to calling me, like what has got you to this point, a little bit about your history and your journey so far. And we kind of just help break things down and get comfortable with one another. And appointment attendee service is another one that you'll hear tonight. This is where I attend appointments with patients virtually.
Sure.
So when they're going into their clinic and they're meeting with their doctor, we have beforehand prepared all of their questions. I take the notes so that they don't have to worry about not remembering anything. And then after the appointment, we connect again to go over everything that was discussed to make sure that they really have a good understanding of what was talked about at the
Right.
appointment. I also do injection training, virtual and in person. So if you're local to the London area, then I'm happy to drive to your house and do your injections for you, certified and insured, of course. I know clinics provide information or instruction from the nurses, and
Yeah.
a lot even provide YouTube videos, which is really awesome. But I always say that YouTube videos can't answer your questions, and doesn't always remind you to kind of lower your shoulders from your ears and to breathe and all of that kind of stuff.
Right.
So injection training is a big piece of what I do. On top of that, we're looking at the continuous support throughout the length of your journey to pregnancy. And as a doula, I work with people through their pregnancy, their labor, their birth, and postpartum, including childbirth and newborn education.
Fantastic. Very cool.
It's a lot.
That is quite the
I also work for
repertoire
a
for sure.
surrogacy.
Yeah.
Yeah, I also
Absolutely.
work for a surrogacy and egg donor agency as well. So I literally live and breathe this stuff 7 days a week, like you do. It's great.
That's right. That's amazing. Yep. Yep. Amazing. So share with us like a couple of stories of interactions with clients and what you've done for them and how it kind of benefited them and that kind of work that you've done.
Sure. So I've taken some of the recent patients that I've worked with
Sure.
from 2021 and 2022. I've worked with them essentially from preconception to parenthood or very close to getting there. So the first one that I want to talk about, it's a husband and wife couple. She's 33 and he is 30. She has PCOS and he has some male factor issues with a lower sperm count and some poor quality. And she discovered me actually on Instagram, and I've been supporting her since January, so for 9 months now.
Awesome.
Her support includes a lot of the virtual calls, and I don't have like a package. I don't sell a package where it's like, we're going to work together for a year and here's the price. I like to leave it up to the patient that when they feel like they need the extra support, then they just reach out and we set something up.
Okay.
So I find every couple of weeks, as you're going through the different appointments and meeting with different professionals in the industry, that it's about every 2 or 3 weeks that we're setting up a virtual call. And of course, text support is included in that as well.
Okay.
She is fairly local, and so I did do her injection training in person. And then we continued just because she needed a little bit of extra cheerleading virtually for the days following that first visit as well.
Sure.
And I've provided resources for her, which was something that I didn't know going through my journey. I didn't know how naturopaths and acupuncturists, and those types of individuals can really help, change your journey and give you a different perspective. And so we talk about those kinds of resources, and she's really built this great team of people. People say it takes a village to raise a baby, but it really takes a village to help make one sometimes too.
For sure.
I think it's important. As the concierge, the idea is, if you go to the hotel concierge, they're going to tell you kind of what's around in your area. And that's what I do for patients, even outside of London, is help direct them to those things within their area.
Awesome.
So ultimately, this couple has had an IVF. They had 2 separate single embryo transfers. It was a funded cycle. They've had both of them turn into pregnancies, and unfortunately, both of them turn into losses. And
Oh,
so even with, this happens, right? Like We talk about different protocol options or things that they can suggest, to their doctor, or things that they can research on their own, in hopes of having a different outcome.
Now, do you help kind of guide them in terms of things that they can offer to the docs, or do you kind of tell them, "Hey, go ask about this," or do you ever sort of guide them to other resources? Like, how does that part of things work?
Yeah, absolutely. So obviously, I'm not a doctor, so I never comment on specific protocols or medications or anything like that.
Sure.
But because I work with so many different clinics and so many different doctors that have their own approaches, sometimes if they're working with clinic A, we'll say, and I know that clinic B or C try a different approach, then I will suggest that to them to take to their primary care provider as
Okay.
a suggestion that, we've heard that somebody else is doing this kind of protocol, and what do you think about using it for us?
Okay. Cool. Tell us about another case.
Sure. So this is a same-sex couple, females, 34 and 36 years old. Excuse me, never had any pregnancies before. I've been working with them since June of 2021,
Okay.
and they were referred to me by a friend who had already used my services. So that was really nice. The partner that wanted to carry actually has PCOS.
Okay.
And again, I was helping them a lot with those virtual calls and continuous text support, as well as helping them with the appointment attendee service.
Oh, okay.
They did ultimately end up wanting a second opinion, which I'm grateful I was able to help them through that smooth transition.
Sure.
So when it comes to referrals to a clinic for a second opinion, um, sometimes paperwork can get lost. Faxes don't always happen to go through.
Yeah.
And so I just kind of work as a liaison for the referral process to follow up with reception and make sure that it's been received. And
Okay.
it just kind of makes the patient feel better that, it's not just sitting in a pile somewhere.
Yeah.
So this particular couple, I did help them with a transition to a new clinic. And they were considering two options with donor sperm, obviously. They were looking at either doing IUI or IVF. And ultimately, them and their clinic had decided that IUI was the best place to start.
Okay.
And so they did it, and they did have success.
Oh,
Uh,
fantastic.
yeah, so I followed through with them and did their childbirth and newborn education as well. The one partner in this couple had never held a newborn baby before. So it's really, people don't think about, just putting a diaper on a baby, or how to swaddle, or umbilical cord care, those kinds of things.
Yeah.
You actually get home and living it every day. So I supported them that way, and they now have a really healthy and happy baby girl.
So, do you find more of your patients are patients that are looking for IUI or more for IVF, or is it kind of a 50-50 split?
It's kind of a 50-50. It really depends on where in their journey they came to me. Like maybe they've already been doing this for 2 or 3 years and they've just discovered that this additional support exists. Maybe they're just thinking about starting to have a family and they've discovered me from the beginning. So every story is so different.
Sure.
uh, Kind of where I jump in and help.
Do you want to share any other cases with us, or
Yeah, sure.
yeah,
I have one more that I picked.
yeah,
I really liked this couple. She was older maternal age. She was 48 and her husband was 40. She has two grown children, and together they didn't have any, and they wanted to have a family together. And so she had found me through a local Facebook kind of business page, I guess.
sure.
And um, they were going the egg donor route. And so I helped guide them through that process in finding and choosing an egg donor. And they did IVF successfully. I helped her with her injection training, the virtual and text support. And again, they were fairly local. So I did their childbirth education and their postpartum care as well, because I think it's so important when you get home with this baby that there's this familiar face to come
Yeah,
into your home and really help make sure that everyone is coping really well with, sleeping and latching and feeding and bathing and all of the stuff.
I think you mean lack of sleeping, but anyways,
Yeah,
yeah,
lack of.
yeah,
Yeah. Well, my job as a
amazing.
postpartum doula is to help with that, right? So if you want to have me into your home so that I can tend to baby and you can sleep or shower or shave your legs or whatever it is you want to do, then you know that you have somebody there that's going to take care of your baby just like it was my own.
That's amazing. I didn't realize that doulas actually go in after the delivery as well. So that's really great. How do people get in touch with you if they want to find you and use your services?
Yeah, thanks for asking. I'm on all of the socials, basically Facebook, Instagram, and TikTok, all under London Fertility Concierge.
Okay.
And my website is www.londonfertilityconcierge.com. And my cell phone number is listed everywhere. And you can just text or message or email.
Awesome. Well, thank you so much for joining tonight and sharing these amazing stories. And we know that we love what you guys do. It does really actually help patients' journeys when a fertility coach is involved. So, a lot of people are like, "Why do I need that?" But it actually can sort of act as a very useful buffer between the clinic and the patients, and kind of make that transition, like you said, a lot easier. Especially when you're entering something kind of scary and unknown, and there's already enough angst going into the whole process. So thank you for what you do, and we certainly appreciate your services. So thanks for joining us tonight,
Thank you.
and we'll definitely talk to you again, I'm sure, sometime in the future. Thanks, Mel.
Okay. Sounds
All
good.
right.
Have a great night.
Have a great night. Take care. Bye. Okay, well, thank you to Melissa. Obviously, a very educated and talented young lady who's made a big difference in a lot of people's lives, which is great. So I think we're going to just go straight to questions. I have a great article to present for you guys probably next week. And the week after, I think we're going to have a guest doctor on with us. So we'll see what happens with that.
You ready?
I am ready, yeah. After our
Completely primed.
After our technical glitch, yeah.
Major technical glitch.
Yeah.
The world fell down, basically.
Yeah.
Oh, yeah. Well, they need that. More glitches as it goes.
Okay.
So, hi, honorary Dr. T.
God. I don't know how much more of this I can take.
And MDRV.
MDRV. Okay, that's
There you
good. Yeah. MedRev.
Yeah. I'm 41.
Okay.
AMH 10.
Okay.
BMI 32.
Okay.
Had 2 miscarriages.
Okay.
No PCOS
Okay.
or endo.
Okay.
Follicular count 8 and 10.
Okay.
Recently diagnosed with Hashimoto's and under meds and no male factors.
And what? Under meds?
Yeah.
Okay.
My funded IVF cycle about to start, and the doctor recommended a short antagonist protocol with stim starting CD2.
Okay.
Is this the right approach? I welcome any feedback. Thank you so much. 3 thumbs up.
So yeah, that is the right approach. If you have 8 and 10 follicles, which actually doesn't really go with your AMH level, but we'll let that slide, then an antagonist approach would definitely be a reasonable approach for you. Make sure your thyroid is very well controlled. I would recommend inositol and selenium to keep the antibody levels down as much as possible. Take a reasonable dose of drugs. Cycle day 2 start is totally fine. Cycle day 2 or 3 will both give you a good result. So yeah, that's what we would probably do for you as well. Easy peasy, beautiful.
Easy, easy, beautiful. Any advice for improving sperm morphology? 95% head defects.
Ooh.
I already did some varicocectomy. Absolutely.
Yeah.
Stopped smoking.
Yeah.
Drinking.
Yeah.
And drug use.
Okay.
And still had a bad morphology. 95% head defect.
So, I mean, it depends on how long it's been since you've had all that stuff done. If you just had your varicocectomy, it'll take a while. If you just stop smoking, drinking, and using drugs, it'll take a while. Make sure you're taking fertility vitamins. Keep your testicles cold. Ejaculate every day or every other day. All of those things can help. If weight is an issue, get your weight down as well, because high weight equates in men to high estrogen levels, and it actually counteracts the sperm. So those are the things you can do to improve it. Beyond that, there's not a ton you can do, but those are the main things. And then, of course, doing IVF will help solve the problem with the morphology because we can actually pick the good sperm.
ATV.
Hey, TV. Yeah, that's good.
That's good, right?
That's really rich.
That's good.
Yeah.
My favorite dynamic duo. So I shouldn't have even stopped it.
You should have just
my favorite dynamic duo.
Yeah, yeah.
It just gets better.
You put the wrong emphasis on the
I
wrong
like that.
syllable.
I thought that needed a stop. It's just too many compliments in one.
All right.
I'll be using delestrogen for FET.
I'll be using estrogen for FET.
There's no such thing as delestrogen.
Del estrogen?
Could be a typo. All right,
No.
estrogen it is.
Okay.
Okay, for
Yeah.
FET.
Yeah.
That's why you're the doctor.
There you go.
Yeah. What level should estrogen reach but not exceed? Tried for letrozole cycle, but doc doesn't want to. Also, any tips for IM injections, both estrogen and PIO, to make them more bearable? Thank you both for all you do.
So don't use estrogen if you can avoid it. If your doc doesn't want to use letrozole, convince them otherwise. Just show them the studies. There's so many now. But if you have to use estrogen, you either use oral or vaginal. You never need to use injectable estrogen. So that's that. As far as the level, there's one study we reviewed a while back that said that it should be around 100 picomoles, but nobody really pays attention to the estrogen levels because it's really not clinically important what your estrogen level is. What's really important is what's your lining doing. So you just need the minimal amount of estrogen necessary to get your lining to develop, and that's about it. From progesterone, definitely PIO and vaginal progesterone. Those are both important at the same time. In terms of how to make it easier, people talk about icing and warming and the location of the PIO and which needle you use and all that stuff. The truth is PIO sucks. So there's no getting around that. It just sucks. Anybody that says that their trick works is just not really being sensible because there are no tricks that work. PIO sucks. However, it does work well. So even though it sucks, we need it in order to get you through to where you want to be. So, I wanted to be an OBGYN. So I literally went sleepless for most of my life and 5 years of residency, staying up every 3 nights, all night long to become an OBGYN. It sucked, but it got me to where I wanted to go. So sometimes you have to make those sacrifices. There hopefully will be a better way at some point in the future, but until we get to that stage, this is all we got, guys.
I'm working on that.
You're working on that, yeah. I don't even know where you come up with this stuff from.
Seems like it's a gap for me to work on.
Oh, goodness. All right.
Okay.
Yep.
Dr. VNT.
Okay.
I keep seeing women talk about prednisone for their FET.
Yeah, sure.
What is this used for?
So there's some theory that blastocysts will do better in a steroid environment. Some of that data actually comes from Richard Scott, who says he looked at it years and years and years ago and never published it, but showed that it was beneficial. So he's always done it. For some people, we use it because they have an immune issue and we need to kind of quell their immune system. So there's different reasons to do it. You can just do it kind of garden variety for everyone, which we do. And then you can extend it past the first 5 or 6 days for the patients that need it for immune suppression. And it's just to kind of tame your immune system so it doesn't attack the embryo.
Hi, Dr. VNT with stars in the eyes.
Oh, very nice.
Yeah. Last week, you mentioned you shouldn't use Lupron in a natural cycle. What if it was used during an IUI cycle? For example, natural LH rise and then triggered with 4 milligrams of Lupron.
Oh, yeah, there's nothing wrong with that. I'd probably still use some HCG though, because you want to still get the benefit of the egg maturity and egg quality. But yeah, that's perfectly legitimate. You could do a Lupron trigger for your trigger. That would be okay.
Hi, TV team.
TV team. TVT. It's a type of urethral bladder suspension
No,
technique.
that's not what. No, we are not part of that. That is the wrong show. No.
It's the transvaginal tape. Anyways.
It's not the team we're playing for.
Okay, go on.
You have to be a doctor right there, right? That's
That one you needed to know. Yeah.
that's what we needed to know.
I've done them many, actually.
Yeah.
I was quite good at it.
I keep having chemical pregnancies, implantation failure.
Oh, I'm sorry.
I'm 28.
Okay.
I have Crohn's disease.
Oh.
And I'm being treated with steroids, interlipids, and baby aspirin. Would you do anything else?
Yeah, I do Humira. And I would check everything on you. And if you're in a flare, I wouldn't transfer. So Humira is probably very useful for someone like that. We don't use it very often at all, but it's reasonable. I would run a full immune panel on you, and I would also do the infection panel as well from like we use Fertility. So that's a very reasonable thing to do. There's definitely going to be something wrong. You may need sort of fairly high dose steroids, intralipids. You may need tacrolimus or sirolimus. Humira will help you quite a bit. So quelling the inflammation would be very, very important in your case. So yeah, there's a lot of stuff that needs to be done. I would definitely talk to a reproductive immunologist or call us because I do a lot of that stuff as well. Or any expert that you feel comfortable with that has experience in those areas. Crohn's disease patients are tougher than normal, and your miscarriage risks, even your stillbirth risks, are higher. So we have to take very, very close care of making sure every single detail is perfect for those patients. You're a tougher group than normal. I love a challenge, so you're welcome to try us, but they are a tougher group. Knock wood, I've never had one that I couldn't successfully help conceive, but it does take some extra effort. Yeah. Great question.
They asked this question in question order and then compliments.
Okay.
I'm going to read it compliment first.
No, just read it like they wrote it. Go for it. And then you can compliment.
It's better this way.
It's better this way. All right.
A big shout out to Dr. V.
Aw, thank you.
Always keeping it real. And the man behind the scenes, Mr. Tart. You guys make an awesome team, and you guys are hilarious. I love you too.
Aw, thank you.
And that's the question.
Okay.
You ready? It's huge.
It's huge.
That's
okay.
why I had to prep you.
I'm going to take notes.
Maybe.
Okay.
Yeah.
Okay, go.
I'm 34.
Yeah. Okay.
Unexplained infertility.
Okay.
I believe I may have lean PCOS and or endo.
Okay.
BMI 18.
Okay.
4 embryos.
Okay.
5 AA.
Okay.
3 AA.
Okay.
AB.
Just AB? Oh, probably 3 AA, 3 AB. Okay.
And then another AB.
Yeah.
And then 1 failed FET. 5 AA.
Okay.
I had a very small polyp.
Okay.
My doc said it wouldn't interfere with my first embryo transfer.
Oh.
My clinic won't treat or investigate mild endo or lean PCOS.
Okay.
No special endo protocol. I suggested letrozole, but my doctor said a natural cycle would be better for me without letrozole. He recommends a polyectomy before the next transfer.
Polypectomy.
Yeah, polypectomy. Yeah. Would that improve my chances? ? What would you advise? ? And how soon can we do a transfer after the surgery? It's big.
That is big. I'm glad I took notes. Okay. So I'm still writing notes. Okay. So number one, you should never transfer with a polyp there. It's a 50% reduction in success and 100% increase in your miscarriage risk. So get the polyp removed for sure. How long do you need to wait? Depends how big the polyp is, but usually you're ready basically the next month. As far as other things that you can do, so for the endo, we do encourage surgery, and then we encourage a Lupron and letrozole for 3 months, and then you do the transfer because there's evidence that that's beneficial. You can also take the 4 supplements that are recommended. So NAC, coenzyme Q10, curcumin, and resveratrol. Those are all beneficial as well to some extent. if you can get surgery, that's definitely a reasonable thing to consider. I would actually strongly encourage you to gain weight. 18 is very thin. Women that are very thin, because you're technically underweight if you're at 18, actually have a harder time getting pregnant. So gaining weight will actually boost your ability to stay pregnant. If you're lean PCOS, it can be harder to gain weight. So you have to carb load for a while. So basically, we tell all our patients banana splits at nighttime. It's impossible not to gain weight if you do that. Tarek and I can vouch for that. So
Maybe that's the problem. That could be my problem.
that's probably both our problems.
Problem right now.
Yeah. One of our patients brought us a bunch of baked desserts, and Tarek and I literally sampled every version of it that was there for dinner.
I even said carbs get a bad rap.
Yeah.
That was my line for the day.
So, definitely try gaining some weight. Take the supplements. Convince your doctor to put you on Lupron and Letrozole, and then use a Letrozole protocol. So Letrozole is better than natural. That's been proven. But in an endo patient, it's extra better than natural because you're actually keeping the estrogen levels a bit low. So that's what you want to see. And make sure you get your polyp removed. Good question, and thank you for all the compliments. That was very lovely. And I'm losing my voice, so I'm going to dive into my giant water bottle. You ask and I'll drink.
I might even be able to answer. Who knows?
Yeah. And yes, this is the world's biggest water bottle. This is what prevents kidney stones.
Does hematosalpinx equal fallopian tube removal? What threshold matter for decision making? You both are the best.
So hematosalpinx, a hematosalpinx means your fallopian tube is filled with blood. So that definitely needs to come out. The inflammation from that would be huge, and the infection risk would be huge. If you have hydrosalpinx, it should also come out because it's a 50% reduction in your IVF implantation rate. So we always recommend removing the hydros, no question.
I'm assuming at 15 to 16 weeks, it's normal to not have any symptoms, question mark. I never even had morning sickness, and it's too early to feel movement.
Right.
It's hard to stay calm and trust my body.
Your body has gone through billions of years of evolution in order to be the body that it is. And it does know what it's doing after billions of years in most cases. So trust it a little bit. And if you're worried, just go see your doctor and ask for an ultrasound. I mean, it's easy. We just pop the ultrasound on, or a Doppler, and you'll know that the baby is fine. So there's nothing wrong with being nervous. I mean, it's understandable to be nervous. Fertility patients live in this paradox where they're happy that they're pregnant and they're terrified that they're pregnant. And you just got to learn to deal with the fact that it's okay to be nervous and be happy at the same time. It's a tough thing to learn, but it's part of the journey for you. So if you're nervous, our job as your doctor or doctors is to take care of you. And part of that is alleviating your anxiety.
My job is to make them smile.
Your job is to make them smile. Yes, that, and to keep the show running.
Not cut out.
And not cut out. Yeah.
Does exploratory endo lab require excision expertise versus ablation? Does salpingectomy require specific techniques to prioritize? Thank you so much.
Okay. So this is something that comes up all the time, and there are all sorts of people on the web who are hell-bent on trying to convince people out there that you need excision surgery instead of ablation surgery. So the truth is, there's virtually absolutely no difference between ablation and excision. There are some instances where excision is better. It's when you have something called DIE, which is deep infiltrating endometriosis. But if it's just superficial, there is actually no difference between excision and ablation. Now, do you need someone with expertise? You should always get your surgery done by someone with expertise, because I have seen the surgery videos of people that were supposedly good gynecologists, and some of them are amazing and some of them are not amazing. So make sure you are always going to someone that is a true expert in minimally invasive gynecology and who has either fellowship training or a hell of a lot of skill and experience doing advanced minimally invasive surgery. If they're not comfortable doing deep infiltrating endometriosis, then that's not the right person to even go into the OR with. What was the other part of the question? It was
salpingectomy.
Oh yeah, the salpingectomy. Yeah, so the technique for salpingectomy, or salpingectomy as we call it, is essentially just staying tight under the tube. You don't want to get too close to the ovary because almost every instrument we use has thermal aspects to it. So whether you're using ligashure or harmonic or NSEAL or whatever device it is that we use, they all essentially burn the tissue one way or another. I'm a big fan of the harmonic scalpel because it only has 1 millimeter of lateral thermal spread, so it does the least amount of damage of any instrument. But you still have to be careful even with the harmonics. So you just need to stay tight under the tube in order to miss compromising the blood supply to the ovary, because the heat does travel and it can compromise it. Aside from that, there's no special technique other than be careful when you're operating.
Lupron Depot or Lipron Micro for down regulation?
Lipron? They must have meant Lupron again. So Depot is for down regulation. Microdose Lupron is actually for up regulation to stimulate you when you have weaker ovaries. So they're used for two totally different things. You use Lupron Depot when you want to shut someone's system down, fibroids, endo, you're going into an IVF cycle or an FET. But you use microdose Lupron when you want to flare the patient to get the FSH and LH to really respond so that you can recruit more eggs. So we use that in patients with diminished ovarian reserve or really sleepy ovaries to kind of wake them up and then push them.
Anything I can do to increase AMH? I'm 35, AMH of 1.21 going into FET 3 and convinced clinic to do letrozole protocol.
Oh, good for you. I guess our message is working, right? So you don't need your AMH increased if you're going into an FET, but just for the sake of answering your question, check your vitamin D because it can often skew your AMH. Make sure that's okay. Make sure your weight is appropriate. Minimize inflammation in your body. DHEA may help a little bit. Testosterone priming will probably help a little bit, but there is no concrete 100% way to increase your AMH. It is actually very difficult to alter. Yeah. Not the easiest thing. You know, this new chair makes my butt slide out of it. Like I feel like I'm sinking out of the chair.
You know, chairs is a very complicated thing.
Chair is a complicated.
Complicated thing.
The last one lost its height adjustment. It needs
bailed on you.
It needs Viagra, man.
You figure it would know better.
You would think in a fertility shop. Yeah.
It's a little embarrassing.
Yeah.
Hi, Dr. V. And T? Somehow there's a question mark after T. I'm not going to read that. I don't like there's a question mark.
Yeah.
Anyway, it's obviously for you at this point. Hope you're doing well.
Yeah.
Another question mark.
Okay.
I did natural IVF last cycle, couldn't retrieve the egg. They said too late. He asked me to trigger with Overdrol and have intercourse at home.
Okay.
Would it help?
Would it help?
Could it?
Yes.
It continues.
Okay.
We have male factor. He said I could get pregnant. He also advised me to start estrogen a week before period so we can do stimulated IVF this time. Will it affect the baby if I am pregnant?
If you're pregnant, you're not, taking the estrogen? No, not for that short a period of time. But don't estrogen prime. It's been proven to be detrimental, so we don't recommend using that.
Hello, doctor.
Hello, doctor.
This is just you, man.
Just me?
Yeah.
Okay.
If you have a large number of follicles.
I still love you, though. Don't worry.
I appreciate that. That is what I appreciate.
Yeah. Large number of follicles.
The questionnaire is quite lucky that I'm even reading it out loud at this point. But go ahead.
Okay.
Large number of follicles. Would you advise on a mini O normal men protocol?
Okay.
Scared to overstimulate.
No, because overstimulation is not a big deal. We just give you a Lupron trigger and you do fine. So you'll be perfectly fine with making lots of eggs. Don't overdo it. You don't need 50. But if you can aim for 20 eggs or 25 eggs, that's fine.
Hi,
So I wouldn't do many.
Hi, Dr. Victory.
Hello? I can't even look at you.
I don't know what's wrong with these people. It's like, where's the love?
Tarek's feeling very unloved, people. Send them some hearts or, happy faces or
Need
something.
some love.
Yeah.
Can you explain how having a high percentage of NK cells
Yeah.
impact fertility?
Well, no one knows for sure, but the theory is that the NK cells, which are NK because they're called natural killer cells, are involved in termination of foreign agents, and that they likely either interfere with the process of implantation or directly interfere with the embryo's growth and development. So you need some regulated immune activity to facilitate implantation of the embryo, but you don't want it to be overactive or it can interfere with implantation of the embryo. So the NK cells are involved in that process, and that's one of the theories of how they are detrimental when they're either overactive or excessive.
U.S. doctor uses estrogen versus letrozole. I think it's a U.S. thing. Is there any studies that letrozole should be used during FET?
Yeah, there's tons of studies of letrozole used during FET. I think we did it last time, didn't we?
I think there's $1 billion.
Oh yeah, it's still up. I just turned on to the I just turned on to the thing and it's there. Here, I'll share. Oh no, we're still sharing?
No, we
We're
never
not
actually
sharing?
ended up sharing. Hold on. I think you're sharing, but hold
No,
on.
I'm sharing.
Yeah, you are sharing.
Yeah, I'm
Just your
sharing.
let me just turn you on.
Yep.
Go ahead.
Okay, so if you look at this screen, guys, this says letrozole and FET on PubMed, right? So pregnancy and neonatal outcomes, endometrial preparation for women undergoing embryo transfer with frozen embryos, ovulatory rates, clinical pregnancy rates among anovulatory and oligoovulatory women after letrozole versus hormone replacement. Like there's tons of them. It's not even just one. There are 31 different studies to answer this. So I kind of chuckle when I hear that some people don't want to do it because they clearly are not reading. Like I get it if it was one obscure study. 31 is kind of hard to argue against. Yeah. Really hard to argue against. I can't solve everything, man. Yeah.
He asked me to start a estrogen a week before my period so we can start stimulated cycle. Will it hurt baby if I'm pregnant? You answered that.
That.
Yeah.
Yep.
Is there a study done to see what vaginal progesterone is best?
Oh, no. So the three big ones are prometrium, crinone, and endometrin. So prometrium, you have to take a lot. There's 2 pills 3 times a day. Great drug, works really well, no issues. Endometrin is 1 3 times a day, and everybody calls it vaginal fizz pop because it kind of fizzes and then it drizzles out this fluid. So some women don't like the feeling, but it's only 1 tab 3 times a day, so it has some advantages. In a head-to-head comparison against, I think it was crinone, it had non-inferiority, which means it was just as good. And then there's crinone, which I probably like the most, but is not always covered, so it's hard to get insured, at least in Canada. And the nice thing about crinone is it's only twice a day, and it's like a gel, so you can kind of scoop it out easily, and it doesn't leave that much residue, as long as you do scoop it out, because every once in a while some people forget to scoop it out, and then they end up with a crinone tumor, which is this giant ball of progesterone in their vagina. So don't do that. Make sure you scoop it out. But yeah, otherwise, those are the three. There is no evidence that any one of those is better than any of the others. I'm probably partial to the crinone just because I think it's a great product and we seem to have our highest success with it. But that's just my gestalt, and I haven't studied it per se.
Can you explain the difference between gonal F and Menopur? What is better?
Um, it isn't better. It's the fact that you probably need them both. So gonal F is a recombinant FSH. It's made in a cell line in a lab, and it is pure FSH. There is no contamination in there. Menopur is a urinary derived product that is highly purified FSH, but highly purified includes some contamination with HCG, which is really good for your egg quality and your outcomes. So what you want to do is use Gonal F, which is a really strong product and has amazing results and a long history, or some kind of recombinant product with some kind of urinary product, because there's a British study that shows that a balance of the two gives you the highest yield of genetically normal embryos.
Can a man compensate bad sperm morphology? 95% had defects with bigger sperm volume.
Mathematically, yes. That's the same guy that was asking us before. Why does this kid always call me in the middle of the show? My son is calling me, which he always does in the middle of the show. Morphology. So let me do the math for you. So if you have 10 million sperm per milliliter, which admittedly is a low count, but let's just use that number, and you have 5% normal morphology, so you basically have 5% of your 10 million, which is 500,000 sperm, which are normal. So if you have 1 milliliter, that means you have 500,000 normal sperm. If you have 2 milliliters, you now have 1 million normal sperm. If you have 4 milliliters, you now have 2 million. So yes, you can compensate by having more volume, because it just means there's more of the number of sperm that you have that are normal. So yeah, it does to some extent, but it depends on whether you're talking about trying to conceive naturally or with our assistance. With our assistance, we actually don't need a ton, so it's fine. We can do it with what you get. If you're talking about trying naturally, yeah, it'll help a little bit, but you're still going to be hampered by the fact that the overall number of normal sperm is quite low. So that's a harder situation.
Is there any scientific proof for the efficacy of fertility vitamins? I have seen in YouTube another fertility specialist that says vitamins have no proof for improving fertility and outcome.
Yeah, so it's very controversial. There are certainly no direct studies that show that if you take this vitamin, it'll change the outcome of live birth, or that vitamin and it'll change the outcome of live birth. But there are lots of linkage studies that show that, for example, low vitamin D has a higher association with infertility and miscarriage. So it's kind of a no-brainer. Like, there are some things where you can't say, oh, there's no evidence. It's true there's no direct evidence, but there's enough indirect evidence to make it patently clear that you need the vitamins. So it's kind of silly to argue that stuff, because, like, for a physician to argue that, because it literally doesn't make any sense. There's no way you can say that a low vitamin D is associated with an increased risk of miscarriage, which is true, but then say I don't need to take more vitamin D because no one's shown that taking vitamin D reduces miscarriage. I mean, it doesn't, like, that's so illogical, it's irrational. So if you can show that the absence of it is bad, you have to assume that the presence of it is going to help. Can we say that definitively? No, but it's a pretty safe bet. And realistically, most vitamins are harmless. So as long as you're taking it with the advice of your physician, you're not going to do any damage.
What is the size of egg to trigger natural cycle? I was 18 and they asked for a blood test the day after and they said it's too late. Canceled the cycle.
We would do it at 17 to 18 millimeters for a natural cycle.
There you go. Hi, Dr. B and Techie T. Oh, I finally showed up.
Techie T, you got a nickname too. I like that. Yeah.
My IVF was converted to an IUI.
Okay.
Doctor said trigger with all of the 1,000 IU pregnal for my one follicle.
1,000 or 10,000?
10,000.
10,000. Okay. Yeah.
For my one follicle.
Sure.
Holy cow. Is that too much trigger?
No, I mean, for one follicle, you probably could have gotten away with 5, but there's nothing wrong with taking the 10. It's just going to assure that you trigger.
Does a
Holy
consistent 9 to 10,000 white blood cell count mean there's inflammation that could be worth extra testing to inform FET protocol?
I don't know where you're talking about the white blood cell count. Are you talking about in the ejaculate or in you? In you, 9 to 10,000 is normal, so there's no inflammation. If you're talking about ejaculate, that would be like insanely high. So yeah, that needs to be looked at.
Would persister? Maybe persistent headache and tiredness? Yeah.
Yeah, persistent. Yeah.
Headache and tiredness be enough to delay retrieval? Thank you.
No. I mean, if you're tired, if you're exhausted, if you've got a bad headache, we're still going to do your retrieval because we don't want to waste all the effort you've put into it. Plus, we knock you out. So, you're going to be very comfortable when you come here and your headache will be gone.
Do you recommend any supplements for male fertility?
So there's this really great study I used years and years ago that demonstrated how many guys and women actually are deficient in various vitamins in North America. So you can go through it and kind of look up what vitamins are good for what parameters in sperm. And then you can take each one individually, or you can just go buy pre-made ones. So I religiously don't promote any specific product over any other on the show. But I can say that what our pharmacy carries is Fertile Pro and Pro Fertile, and we're perfectly happy with the results from both of those. So either one of those will work. Pro Fertile is the only one in Canada that actually has Health Canada approval. So they actually have to go through the rigorous, studies to demonstrate that their vitamin actually helped, and it did. So it's good. It's expensive, but it works really well. Fertile Pro is a great product too, and it's made in Canada. Pro Fertile, I think, is from Austria. So I'm happy with either of those. We've seen loads of other vitamins from other places. They're all good too. Whichever one you want, go for it.
If I ovulate late day 21, does it mean the egg is bad?
Yes, most likely either the egg is not great or your lining is overbaked by that time. So we don't love people that are ovulating that late. I mean, I love the people. We don't love your biology. So we would typically give you letrozole or Clomid to speed things up.
Asked the doctor for progesterone in oil. She said it's not available in Canada or in Montreal.
That's totally not true. Yeah, it's readily available in Canada. So I don't know what to say about that one. New time for a new doctor.
They're in Montreal.
Oh, that's okay. You can reach out to us. We can ship it to you. Call Twin Oaks Pharmacy. They'll ship it to you.
What kind of numbers are we looking at when we get to our day 5 or day 6 embryos? Our donor had her egg retrieval on Monday, and we are down to 20 fertilized eggs at day 1, which is today.
Wow. So how many are you expecting to get to day 5 or day 6? It depends. So on average, 50%. That's if sperm is good. If the sperm is really good and the lab is really good, you can get higher, like even as high as 70 or 80%. If the sperm is crappy, you can get as low as 30%. So we seem to have very, very high blastulation rates here. So I know, like, for example, especially with our donor cycles, if we get a lot of really good eggs, we'll pretty much get a lot of good embryos. One of our most recent ones, we got 32 and we froze 25 or 26 eggs. So yeah, we do a very, very good job. 25 or 26 blastocysts, sorry. So we do a very good job. Not everybody's going to get that many, but it's reasonable to expect around 50%. So from 20, you should end up with 10.
Should I stop DHEA now that the IUI is done?
Yes. Stop DHEA now that the IUI is done.
Thank you for the amazing weekly fertility education
Oh,
comedy show.
that's nice. We have gotten more comedic as we go.
People
Yeah,
like it.
I know people do like it. It's true. Yeah, yeah.
Hi T and Dr. V.
Okay.
Is it possible to stop responding to letrozole after using it for 10 months?
Well, anything's possible. If you're using it for PCOS and your weight has fluctuated or your dose changed, or maybe you were taking antibiotics or whatever, sure, you could have an off month. I would probably just go back to trying again. If that doesn't work, then you may need a higher dose. And then, of course, addressing whatever problems there are that led to the failure.
Hi Dr. V and the illustrious team.
Now he is happy.
I'm back.
Yeah, I'm gonna have to tie lead weights to his feet so his head doesn't inflate
I
and
was already
float
going
off
up.
the
I'm telling you,
chair.
I was going up. Do you have any information on how shingles can affect implantation? Just had an FET canceled because of shingles.
Well, shingles causes an immense amount of pain and it's significant inflammation. So whoever canceled you did absolutely the right thing. And that can last for months. So they did the right thing by canceling you. The inflammation alone would be enough to mess everything up. So
I got a positive COVID test last Friday.
okay.
I'm supposed to start IVF this Thursday or Friday, Thursday/Friday. Do you recommend to start the cycle anyway or postpone it? Just got mild symptoms. I did PRP August 5th.
Intra-ovarian PRP? Oh boy. So STIM does not ever appear to be affected by doing or by getting COVID. So you're okay with STIM. Would I do an embryo transfer? Definitely no. Not for 2 months. But would I do my STIM? Yes, especially if you did intra-ovarian PRP because that's time limited.
Do you say estrogen priming is bad for IVF?
Yeah.
My doctor wants me to do estrogen priming for an upcoming IVF cycle. Should I discuss it with him?
Yeah, we have an article. What was it, about a month ago? Tarek's laughing. I know it's a thing. We have a YouTube video. I gotta find the YouTube video. We have a YouTube video that showed that it's bad. I forget what it was called. Whoops. It was a couple weeks ago. Maybe it was more than a couple weeks ago. We do so many of these shows. I know. We do a lot of these shows. So how long ago was the letrozole priming one? Will I be able to find it? Is it letrozole? Should you take it? I think so.
Probably, yeah.
Okay, so are you screen sharing?
Sure.
Okay, so if you go to our YouTube channel and you look at Fertility Factor Fiction, and it says letrozole and was that the one? No, that's not the one. It was the estrogen one. Sorry. Single or double trigger. Exposing. We're gonna need to look at it. I have to find it for you guys, but there's one on here that basically talked about estrogen. So we'd have to go through them all. They're all kind of out of order right now. I don't know why.
You must have clicked on something.
I must have clicked on something. Yeah. So look up. Yeah. So look it up on our Fertility Factor Fiction channel on YouTube. It's there. But there's a very good randomized controlled trial which showed that estrogen priming actually decreased your live birth rate. So I definitely wouldn't recommend you do that. Yeah.
Follow up to the NK cell question.
Okay.
What do you do differently in the IVF process to minimize the negative effects of NK cells? And can this be done outside of IVF, naturally or IUI?
Steroids, intralipid, subcutaneous IG. Those are the agents that we know work.
Hello, doctor.
And you can do them outside of IVF. I'm not sure I would. It's a lot of expensive invasiveness to get success without doing IVF, but you can.
Hello, doctor.
Okay. Hello. No tea.
No tea. Yeah, no tea. That's right. I was reflecting on the gap. Would priming help
Yeah.
when start a cycle for egg retrieval? If so, what meds would be ideal?
DHEA, testosterone, human growth hormone. Just those three, nothing else. Don't use estrogen. And for God's sakes, every once in a while, someone says I use birth control to prime. That's the worst thing you can do because it'll suppress you. So don't use birth control to prime.
Hello to both.
Hello to both. Okay. You're getting a little bit of love
I
again.
almost got something there.
You got something, a little something, something.
Do you happen to know if we can order meds in Canada and get them delivered to the United States of America?
Can you? Yes. Will it make it through customs? Probably not. And if customs holds up your meds, because many of them need to be cooled, you're out thousands of dollars. So if you're going to do that, hop on a cheap flight to Detroit. It takes 20 minutes to get across the border. So hop on a car or bus, an Uber, whatever you want. Come across the border, drop off at our pharmacy here, grab all your meds. It's about 30% cheaper than it is in the US. So you're saving yourself all that money. Run back across the border, hop on a return flight, you're home in the same day. We have loads of people that do that. It's like nonstop around here. Yeah. 7 more minutes. We're going to 9:15 because we goofed up at the start.
Technology goofed up for what it's
Technology.
worth.
All right. Yeah,
this
technology.
is out of my hands.
It was out of your hands. You were very puzzled. It's rare that I see you nervous. You were actually flustered.
You know why? The people are waiting.
I know the people were waiting.
Can't keep the people waiting.
No, you can't keep the people
It's not the way I was very.
Yeah, the people and my wife. Anyways, go on.
A lot of wives waiting here.
Yeah.
Could you explain
Yeah.
the right balance of gonal F and many-pore for getting normal embryos? You talked about a study about this.
Yeah. So years ago, one of the first studies we reviewed on the show was this large study from the UK where they showed that the optimal ratio of recombinant to urinary derived gonadotropins was 55 to 45. No one's going to do 55 to 45. So we just do 50-50. So that's how you get the 1-to-1 ratio of whatever recombinant to whatever urinary. So we use gonal F and Menopur or Recavel and Menopur. And that's where that 1-to-1 ratio comes from. It's hard with Recavel though, because Recavel is in a different type of unit. Like they have 6, 8, 10, 12, 11, 9.3, whatever. But it's in like single digits or double digits, whereas the Menopur is 75 units, 150 units, 225, or halves of that.
After a miscarriage, which comes first? Ovulation or a period? I finally saw bleeding and the HCG is not 0 yet, but decreasing. Does it need to be 0 for my body to ovulate again?
Usually, yes. Yeah.
I heard using retinol cream during pregnancy is dangerous. How long prior should I stop using retinol before FET?
A minimum of a month. A minimum of a month.
There you go.
Yeah.
Hi, Dr. VNT.
Yeah.
I did a modified natural progesterone, was 90 nanograms per mil, and my mid lab 98.6. I had a lot of eggs, about 9, and cysts. Was letrozole too high? 9 milligram with trigger. Should do this again. I have PCO. Thanks.
I need to see that one. That was too confusing. Let me see it.
Right here.
Okay. Hi, Dr. VNT. I did a modified natural progesterone was 40 nanograms per mil, and my mid lab 98.6. I had a lot of eggs, about 9, and cysts was letrozole too high. I think they mean was the progesterone too high. 5 milligrams with trigger. Not sure what you're asking there, but that progesterone level is very high. So if that was just from your natural, like using letrozole on a trigger, you can't do anything about the progesterone. And I wouldn't adjust the dose, but that is a really high level of progesterone. You must have very strong eggs, or you released a lot more than you think you did. So I would be careful with that.
If a 37-year-old throws 55 eggs at your clinic,
Ooh. Yeah.
on average,
Yeah.
how many live births could they possibly get?
If a 37-year-old had 57 eggs frozen, how many live births could they get? Let's do some math. I love doing math. Embryo math. This is embryo math.
Should we show your screen?
Yeah, we should share my screen.
All right.
Can
We're
you
going to
share
watch you do screen stuff.
Yeah. So 57 eggs.
Mm-hmm.
So if they're all mature, let's just say 50 are mature. So we're going to say 50 mature. I don't know how many you actually had that were mature, but let's say 50. So if you get 50 that are mature with our lab, I'm going to say that they could probably fertilize. That's a lot of eggs. Let's say they could fertilize 48 of them. 48 fertilized. So then you're going to get minimum, I would say minimum you get 30 blasts with us, minimum, probably more. And at 37, 65% of them will be normal. So you're going to end up with 20 euploid embryos. So from 20 euploid embryos, you should be able to easily achieve 8 live births.
There you go.
That's assuming everything works out perfectly. If you have less mature eggs, if the sperm's really crappy, if there was an egg quality issue, whatever, that's a different story. But if everything's perfect, you'll get 8 live births. 7 for sure. It'd be kind of shocking if you didn't get 8, but yeah, you could literally have a huge family from that many. Yeah.
57 eggs, man.
That's a lot of eggs.
Wow.
So that's what I would anticipate with us. I mean, that's what we routinely do with our donor program, right? We get like 40 eggs and we make a whack load of embryos for people, and they have a ton of embryos. I actually had someone today that didn't know what to do with her 21 remaining embryos, so we're trying to get them to donate them. Yeah. I think we're 9:14. One more question.
Okay.
Tarek's choice.
Cool. Tarek's choice.
Tarek's choice. It's always Tarek's choice.
Well,
The whole show was kind of Tarek. We should just call it Tarek's choice. Forget fertility factor fiction.
you'll be my assistant, the guy that answers the questions.
Okay, I almost spat out my water on that one. Yep.
Okay. Last question. Okay.
Last question.
Let's see if anyone gave me a decent intro here.
I got a question. Okay, I'm going to ask a
there you
question.
go.
Let me ask a question. We put out 2 great videos. One was the top 5 adjuncts that you can use for your FET, and the other one was the top 10 reasons that your IVF cycle failed.
Mm-hmm.
But despite the fact that most of our videos do quite well on YouTube, those 2 have been very slow. So I want some feedback from you guys as to why more people are not watching those 2 videos. Because I thought they were really helpful, very simple, short. They kind of go over everything you need to know. But for some reason, it hasn't gotten that much traction. So give us some feedback as to what we could do to improve it and make it more popular.
Put the comments in
the
video.
Yes, put the comments on the video so we can actually get them and then know what to do with them. I wish you all a good night. I need to go home to wifey. Tarek needs to go home to his. And
Robert might not want me home.
Yeah, might not want me home either. So make sure you guys stay tuned. Next week, we will review whether testosterone priming is beneficial and how beneficial it is. And we will see you again on Fertility Factor Fiction. Thank you, as always, for watching and your support. We love you all. Have a good night.